Good morning, everyone. So I'm Wendy Nilsen. I'm from the Office of Behavioral and Social Sciences Research at the NIH. I'm also one of the program directors for Smart and Connected Health at NSF. So I kind of come at this from both sides. So we had a meeting on September 10th at NIH that was really looking at what are the technologies in place for aging in place. And so we really wanted to know, I mean, you've heard it this morning, but we're kind of going to summarize it. I think George did a great job of bringing it together. But we really wanted to know what were the gaps. If you systematically looked at it from industry, from government, and from research, what were the gaps? What were the gaps in technology? And I think it's important to note, this isn't technology for technology's sake. That wasn't at all where we were coming from. Technology is a reality. My mother lives with me. She's 75. She burst into tears on the phone the other day. She called me. I said, "What's wrong?" And she was babbling about something. And finally she said, "iOS 8 crashed my iPad and it's dead. It's bricked. I looked on the internet." You know, this is a world we're coming to. It wasn't bricked. It was fixable. And she's happy now. But the thing is that this is the world we're coming to. My child will never walk into a bank. He will never walk into a brick and mortar bank. He will do all his transactions. It never even occurs to him, these things. We have a world that's changed pretty dramatically. And as Eric, I think, in his visionary way talked about, we still think about health in very similar ways to what we did. And so at NIH, we started thinking about what are the gaps? What do we need to know? What are the things that we need in the research space from across this? And really think about, how do we think about, you know, what do we think about now? What do we think about in the next 5 years? And then in technology, it's the moonshot. It's 10 years in technology. It's the moonshot, right? So we brought together all sorts of people, and it was at the National Institute of Health. Travel was funded by the Computer Research Consortium, which is part of the whatever. And yes, thank you. I completely blew that one. So you get by with a little help from your friends, and then from the National Science Foundation. So we all came together and we decided, you know, that we really needed to look at this. So the organizing committee, you can see, was big. I do want to point out my wonderful colleague, Erin Acharaga, in the back. Erin, wave. And so Erin was really the brainchild of this. So, but everybody came together. You can see there are health researchers, technology researchers, industry folks, government. We all came together with the same goal of thinking about how do we pull this together. And some of you in this room were at this meeting, so thank you. We came together really around 4 topics. We really came around things that you've heard today that are really no-brainers. How do we design for this population? Do we design for the 5%? And the population we were looking at was older adults and people with chronic conditions and people with disabilities. So people who wanted to age in place. So how do you think about this population? It isn't one population. How do you design for it? Do you design for the 5%? Do you design for the 95%? How do you think about design, period? What kind of sensing innovations do we need? I work at NSF half my life, and you know, sensing is a huge part of what happens. But sensing is not easy. You see all these little sensors. George will nod his head quickly. You see all these little sensors. It looks easy. It's very complicated. The algorithms are tough. The timing is tough. Collecting data and making it useful, it's tough. What do we needed to know? What do you think about transitions? You're all talking about it in one way or another. How do we help people use technology to really help them through transitions? And then using non-health technologies. Tom was actually one of my panelists on this one. We did one too on policy, but that was involved, intense, and complicated. I know you all have talked about that. So some of my colleagues from FDA and CMS were there. So, but I'm going to really focus on the research needs right now. So this was really conceived from all the reasons you've heard of right now. We were really thinking about, you know, we know that we can increase lifespan, but how do we increase quality of life? Could technology be a part of that? And technology, we were really thinking of technology not as a magic bullet, but I think as you've heard here, technology can do all sorts of things. It can facilitate communication. It can facilitate better data collection. It can facilitate all sorts of things. How do we do that to not only sustain health and keep people healthier in their homes, but also to increase the quality of life? We really wanted people to live in their homes longer. If that's what they wanted, I really can't imagine being moved out of my home. I think it was pretty funny when I looked around the room at the meeting. I think none of us, we were all of an age where we thought, oh no. So maybe this is getting personal. I don't know, but I think it's an important thing to think about. It's obviously the healthcare cost, but it's also the healthcare cost and the quality. Thinking about hospitalizations, rehospitalization, we've heard it to death, but thinking about that in terms of quality of life. Going in an ambulance, staying in the hospital, being in the ICU, none of that's fun. None of that improves quality of life. How do we think about that? How do we keep you healthier? And then the strain on the healthcare workforce. You've talked about it and talked about it. It's the healthcare workforce, it's the caregivers, it's the person in the center of all this. How do we reduce strain on all of these systems that are already doing, and then reducing caregiver burden? My mom lives with me, I love it, but sometimes a phone call with a broken iPad is just enough to kind of get my day confused. So, because I had to go home and unbrick it. So, but you have to think about those things. So, the findings from this, we found out it was hard to talk to each other. It was really hard. I think George was talking and made it look easy. It's hard. It was really hard. My technology folks were saying, we need more basic science. My clinicians were saying, but what about now? So we really thought we really needed to organize opportunities for people to start to talk together. This is a great forum. I think it's just fabulous that you're doing this. But when you start getting all these folks into a room and they're not used to talking each other's language, and somebody's talking about gait and somebody's saying, why do I care about gait? Why do I care about a bed sensor? What does it give me? I need a blood pressure monitor. Don't talk to me about a bed sensor. We really have to do that, and we have to start to think in these conversations so we can transform it from being healthcare at home, which is I think where we're at right now, is how do we think about that, to really transforming health to becoming a smart home where you're healthy. We also wanted to try to, in this meeting, it became obvious that the technology people, we often think of them as technicians. Right? They're programmers. Oh my gosh, my PhD computer scientists at NSF go crazy. We are not just programmers. They're scientists too. But then they say to me, I need a clinician for this study. Well, do you need a clinician? Do you need a clinical researcher? Do you need a health researcher? It's not a clinician. Who do you need? All people who work in health are not clinicians. All clinicians are not researchers. These are from my NSF projects. How do we think about that? Because we're not all one thing. So we really need to think about each other as complementary disciplines that work together for a common goal. And then we're changing, and we're really trying to think about this alternative to care. It's an alternative to care. It was like Eric was saying, when you shift left, can we think about this as a way to keep people in their homes, to provide really quality care? And at the same time, and over time, shift it to that model from just providing healthcare in the home. So I think it's been talked about here a lot, but we were really interested in the topic that came up. How do we personalize? When you look at the human factors research, if you want to look at a glucose monitor, it's not designed for people who have diabetes often. You get teeny little buttons, you get teeny little type. Well, if you've got problems with your vision from long-term diabetes, what do you need? You don't need 8-point type. I don't need 8-point type. I doubt anybody does. But, in order to make these things teeny, we've given it, but we haven't thought about the right people when we're developing it. We haven't thought about that. We also think about developing this, for the whole. We got to do it for everybody now, instead of how do we come up with some basic principles that allow us to personalize for people. So we had people from Tom talking, Dave Gustafson, who has the AHRQ-funded Elder Tree, talked about building tablets that had very simple, straightforward operating systems on them. It made it easy for people who've never used computers to be able to not only do health, but I think one of the important things was it could do social networks. It could easily teach you how to do an email, right? Those are things that are important, but they weave health into it, and they're designed for people in the way they're going to use them. We also were thinking about future-proofing. What we have in technology today, in 5 years, my son keeps asking me, when can we chip his phone into his arm so he doesn't have to drop it one more time and I need to replace the screen? He really wants his screen right here and not in a watch. He wants it in his arm. He wants it done. But that's not what we want. But we have to think about that future as things are changing. And the future is changing pretty radically. And where I am in NSF, we talk about smart textiles. Do y'all know about smart socks? You know, people looking at how do you measure edema through a sock with sensors in it. In China, they're actually rolling out lots of smart textiles in hospitals where your gowns are actually taking measurements. So thinking about how do we future-proof with all this coming down the line. We also didn't want technology for technology's sake. We really wanted to think about technologies that empowered people. So one of the discussions we had in this meeting was technologies in a smart home to keep an eye on you so that your family knew what you were doing, or was it to enable you to be independent longer? Because the frame is huge here. And if you think about how do you do that? How do we empower people? How do we think about this? How do we work with consumers, which we often call patients, but how do we work with them to find out what's going to empower them in their health? What's going to help them, give them the tools that they need to make this work? And then we didn't want to create another digital divide. As Eric said, sometimes it's the people who can afford it, but technology is really cheap now. And how do we think about technology that doesn't require you to have a PhD or a lot of money? How do we think about that to help people age in place? We also talked about evidence. I think you've heard it here, but we need new methods. We need new methods. I'm at NIH. We talk about randomized clinical control trials day in, day out. We need to think about better ways. We need to think about continuously evolving evaluations where technology, technology can be evaluated on the fly. How do you think about this? And still keep people safe. We need evidence generation, but we need to think about it in a new way. I spend most of my life in mobile. If we can collect better data, more intense, rich longitudinal data, can we then use that in predictive models so that we can run shorter trials, so that we can tell what's coming? This is our future, but we have to really start to think about that. We really need these things evaluated. I hear all the time, I love the study that was just presented. I'd like to see that in a randomized trial, because then we can say, oh, this gives you this. Right now, those are just tantalizing results, great. But I want to see them so we can say, okay, we can develop this as best practice. So we really need to think about that. And thinking about technologies more broadly, again, we weren't about technology for technology's sake at all. How do you integrate it? How do you give people more time to talk? That communication thing. If you don't have to take a blood pressure, if you can actually talk about the dog that died that week, right? Instead of having to take a blood pressure, is that going to be worth a fortune in your care? Probably. So how do we help bring it in and integrate it with other sources? Also, we were also thinking about the Internet of Things. I'll tell you, one of the ways I keep an eye on what my mom is doing is my smart thermostat that recognizes when people are moving in the house. I always know she's up because the thermostat went off. So we really needed technology. We really needed the analytics with it. We really needed to validate it, and we were thinking of ways to validate them in existing trials, to doing it in new trials, in cohorts that are well developed. Could we add on to them? Could we think about community test beds, which, communities where we could augment them with technology to really help us understand what these things mean in real time? Can we develop these new evaluation technologies? We talk about it all the time in the mobile world, and people are working on this. There are new ways, there's new designs, new ways to think about this, but we really need to get these things validated in a way that we can roll them out, and we can help our regulatory colleagues think about this. When we think about it too, we need this longitudinal data, and I think there's a piece that you have to think about. It's today, right? So today we need help now, but also if you think about this data we're collecting to inform discovery science to move us forward in the future, so it's that balance between the two. We also, I talked about this before, but we really needed to think about the person in the center of all of this. There was a human side, and I love the fact that we really were thinking about it from both ways. How do we empower people? How do we make sure it works for people? How do we not design things for us, which is often what happens? I always say if you're in the room with me that you're not normal. You're thinking about this in the way that other people don't, right? When I look at Tom's thought about this in a ways that people on the ground in the real world have never thought about it. So we can't assume we think like everybody else. We really need to go out and figure that out. And we really need to get people talking. We need to talk, and we need to talk frequently. It's hard. I ran an investigators meeting in my Smart Health program, and I'll tell you, one of the clinicians walked up to me, and he's one of the clinical researchers. He said, "I don't get engineers." I said, "It's okay, they don't get you either." So, we have to get to the point where, we always say, if you can laugh at the physicist's joke, we're doing great. So, so we really need this to motivate users too. And it's not just users as in the consumer, the end person. It's the caregivers. It's the care team. We have to give people actionable, useful data in a way that's useful to them. So those visualizations, that's the kind of stuff we have to think about. Not everybody wants to read a JAM article. But with technology, you can go everything from a very nice visualization to a data table to a JAM article. We can do all of them. So that's it. It was a great meeting, and I didn't mention it, but these are raw results from this meeting, and they're really, so they're not, I'm not recommending this from NIH, but it was a great meeting, so thank you.